Fine here?
Mr. Sitole? Ready for your blood test?
Good evening, everyone, and thank you for joining us to discuss prostate cancer. I'm Joanie, Sadie, your host for this evening, and I am the Corporate Relationship Manager for CANSA. Prostate cancer is one of the top 5 cancers affecting men. Unfortunately, it's not often discussed. So at CANSA, we are committed to bringing this discussion out into the population. I'm very fortunate to be joined this evening by Professor Riana Bornman and Mortimer Julius, who we'll dig into a little later. First, I'd like to encourage everyone as part of this webinar to share the information and the highlights that you've heard from this webinar with everyone that you know, everyone that might be affected. Please help us break down the barriers faced by men facing cancer. First, I'd like to introduce you to our first guest, Professor Riana Bornman. Professor Riana has been part of the Department of Urology at the University of Pretoria since 1980. She has done research on South African prostate cancer, and she's been part of the Bornman study. Prof. Riana, thank you very much for joining us. Please tell us more about your studies on prostate cancer in South Africa.
Thank you very much, Joanie, and thank you, CANSA, for the opportunity to share with you the information that we have for South Africa about prostate cancer. Can I have the first slide, please? And I really hope that today will be a day that matters for you. Let's make it matter. Next one. This discussion will center around prostate cancer in Africa. And I hope that you will, by the end of today, realize how important is Africa in our understanding of prostate cancer and the big role that everyone that's listening to this lecture actually can play in this regard. I present this on behalf of myself and Professor Vanessa Hayes. She's from the University of Sydney. She's the genomicist in our team. Thank you. Next one. Prostate cancer, as you heard, is one of the most commonly diagnosed male cancer. It is, in fact, the most commonly diagnosed male cancer. It's second highest mortality in Western countries. The problem is that we do not know what actually holds true for Africa. We do not know the prevalence of prostate cancer throughout the different countries in Africa, but we know, and this is important, there are 3 validated risk factors for prostate cancer. The first one is a family history, and it's both from maternal and paternal sides, and it's about breast cancer, and it's also about ovarian and uterine cancers, and for prostate cancer as well. The second one is age, and the third one is African ancestry. I remember the first time when I read about those 3 validated risk factors, I thought to myself, it's such a no-brainer. It means that we all in Africa should study the role of ancestry contributing to prostate cancer, and that will can make a big difference. Next one. As I've said, there are three risk factors: age, ethnicity, family history. And as I tell the students, if I wake you up at 6 o'clock, at 12 o'clock at night, and I ask you, no, tell me the three risk factors, you should be able to respond with age, ethnicity, and family history. Next. Cancer in the African Americans is higher than in the white or the European Americans. It's 1.7 times higher, their risk to develop prostate cancer. And they usually present at 10 years younger age at presentation, and they have a 2.5-fold higher risk of prostate cancer. So it's not only the risk of presenting, but also the age is younger, and they have a more a higher risk of dying from the prostate cancer. Next. If we consider what's available on South Africa, and it's very limited. There was this one study published in 2014, which indicated that the highest incidence seemed to be in white people, followed by the coloreds, but few of them were diagnosed in the black populations with prostate cancer, and even fewer amongst the Asians. And it shouldn't be like that. The African people being the major ethnic group in South Africa, we should have been able to diagnose more cases of prostate cancer, even way back before the 2015. Next. There's also an age incidence of prostate cancer. We seldom see prostate cancer before the age of 40, 45, and from there on, there's a steep rise to about the mid-70s, and then there's a decline, but simply because there are fewer patients left that can actually develop prostate cancer at that late stage. So the message is the risk group starts at 40, 45 years of age. Next. So when should screening for prostate cancer be done? And now we've referred directly to PSA. In all men after the age of 40 years, we start at 45 years. If you are living in Africa, you're of African ancestry, or you have a family history, we should start with screening PSA from the age of 40 years. We do not understand the role of prostate cancer in African men, but the idea is about screening for PSA to diagnose cancer earlier and to be able to treat it at the time when it's still confined to the prostate itself. Next. We started with a study in South Africa just after 2010, the South African prostate cancer study. Next one. This study was initiated with the support of Dr. Richard Munare, Professor Vanessa Hayes, I told you, and then Prof. Philip Venter and Dr. Smith van Zyl from Polokwane. It was done in conjunction with the MRC and Unistel in Cape Town. Next. Now, the goal of the SAPCS study that was also funded by CANSA was to try and find out genetic markers of prostate cancer risk and aggressive disease within South African men. We looked specifically at the clinical presentation, the demographic, that's the non-genetic contribution, and then, of course, the genetic contribution. Next. We included 917 SAPCS subjects, of which the majority were from Polokwane, from Limpopo, and from Pretoria, 266. Now, I want you to consider this, and that is the reason why these men went to the attending clinic was because of a urological complaint, but a very generalized complaint, not something that points specifically to the prostate. And remember what we heard at the beginning, prostate cancer is a silent killer. It doesn't announce itself openly. Incidental findings of high PSAs, some of the men presented with back or leg pain. Some were during general checkup. Some presented with swollen or injured scrotal region. Also, not surprising, the complaint about erectile dysfunction was in less than 1%, and then many of them didn't give a reason why they went to the clinic. Next. Now, in our patients, the patients in Limpopo were on average older than those from Pretoria. Also, they were older than the study that was done in Australia. So it seems that our men present later with prostate cancer, and also men from Limpopo were on average 3 years later than men from Pretoria. So it means that Limpopo has an inherent risk of late presentation. At the time of the study, we discussed the possibility of traditional healers and their influence on the age of presentation, and I will follow it up with some information later. Next one. Our PSA in our patients were much higher than in Australia. We seldomly saw in the SAPCS subjects men with less than 20 nanograms per milliliter PSA, and in the majority of them, they had PSAs above 20 nanograms per milliliter. So PSA seems to be, in our situation, it could well be a very significant analysis. Next one. In our cases, that means the patients with cancer, they had significantly higher PSA values compared to the control values. And to the extent that one can never doubt when you have a high PSA that this is most probably be cancerous. Next. The Gleason score, that is the percentage of, or the number of aggressiveness of prostate cancer, was higher in the rural area in Limpopo compared to Pretoria. Next. And these are important indicators for us when we consider further evaluation and treatment. Next one, please. When we look at the patients with the clinical presentation of our patients, with Black men with prostate cancer, they had a more frequent aggressive prostate cancer than their white counterparts. They had high prostate PSA levels. And we at that stage wondered whether their lifestyle or environmental factors contributed to their prostate cancer risk. Next. So the first lessons that we learned was that a lack of PSA testing, especially in the rural communities, may be contributing to the aggressive presentation of prostate cancer in South Africa and specifically to Limpopo. It means that in those men, surgery is not an option, which is sad because we can cure men with prostate cancer if we can remove it. And the implication of this was we need to be able to test men earlier. We cannot wait until they present with disease at the 45, 50s, and later on. We should diagnose them earlier so that one can see when the increase in PSA occurs and then start doing biopsies. Next. we know that men are very reluctant to go to the physician and to the clinic. And it's been like this for all ages, only until the time that the boy is taken by his mom by the ear usually to go to the doctor. You find that boys and girls are more or less the same. But from there on, women are more likely to go to the doctor. We should actually, than men are, we should actually use the females in the life of men to motivate the men to go for their testing. Next. We also had a look at the previously genetic and epidemiological risk factors associated with prostate cancer in our Black population. Next one. And what was clear from our findings was that in the African men, the Black men, the African ancestry was linked to high-risk prostate cancer with I'm confusing myself. African ancestry is linked to high-risk prostate cancer. Now, in the African Americans, they do not have CANSA contributions, but in our populations in Africa, we have CANSA contribution. And it seems that the African ancestral fractions to high-risk prostate cancer that occur in South Africa is linked to the CANSA contribution. Next. We had a specific look at 68 Black men, 84 colored men, and they were from Polokwane Hospital, Steve Biko, and Tygerberg. And we rescored their Gleason score for aggressiveness. Next. And of these men, the Gleason score of 8 or higher was confirmed in 33 of the Black men, and only in 26 or 27 of the colored. Let me use the percentages. In 66% of Black men had aggressive prostate cancer, and 32 of colored men. They had high PSA levels, but what was very interesting is that it seems that the prostate cancer, next one please, is linked to the African component of their genomic makeup. So in Black patients, the total CANSA contribution seems to be less significant, but with the colored men, the African contribution was responsible for the high-risk prostate cancer development. Next. This was the first study to link CANSA ancestry to high-risk prostate cancer in colored men. Next. Now, the CANSA were our earliest ancestors of modern men, and they had the genomic signatures for high-risk prostate cancer. And it simply means that in the CANSA, they did not have time to develop a resistance in the genomic sense of the word because of the later onset of prostate cancer. It's not something that occurred earlier in their life, say for the age of 25 onwards. It's something that developed when they couldn't select against it anymore. Next one. Next one. Our conclusions from this study were that the European ancestral risk alleles for prostate cancer are not predictive in Black men. That means if we use the European data, we apply it to the possible risk factors in African men, it's not predictive of prostate cancer risk. We have to develop risk factors specifically for to predict prostate cancer in Black men. And it seems that PSA measurements are essential for Black prostate cancer development. Next. We know about the migrations that occurred through Africa, and that's a reason why we do not have the same explanation for prostate cancer in African Americans than we have in South Africa. Next one. If we think about prostate cancer in Black African men, we have to think better. I don't think we have a choice. It's a guy that said it in 2008 in a book on tribes. We need you to lead us. I think we have no obligation to change the rules, to raise the bar, to play a different game, and to play it better than anyone else has any right to believe is possible. I think very often Africa is being looked at as this poor continent where nothing good can come from. It's not the truth. Africa for prostate cancer will eventually produce the answers to a better understanding of why prostate cancer develops in the first place and what the risk factors are. So we in Africa, we will have to find ways to take hands and to have a united front for prostate cancer in Africa. Next one. We got funding from the Australian government, also from the NIH and from the DOD, that's the Department of Defense in the United States. And we are now conducting a study to try and find out what are these risk factors in our population of Limpopo province, specifically the Vembe area of the northern part of Limpopo province. Next one. We have a multinational team and we have several urologists involved with the studies. We also have community engagement. Next one. And for I want to repeat what Dr. Desmond Tutu said some years ago. There comes a point where we need to stop pulling people out of the river. We need to go upstream and find out why were they falling in. And I think that's what we're trying to determine. Why are men developing prostate cancer? What are the risks for them? Next one. We did a cancer awareness study for CANSA, and where we interviewed with knowledge, attitudes, and perceptions, practices, questionnaire, the nursing staff, and the communities in the villages. We also had in-depth interviews with traditional healers. Next slide, please. What was interesting was that there was really a need for training institutions and regulatory bodies to get involved with the nursing curriculum and to help the nurses develop skills to pick up prostate cancer, to be on the alert for prostate cancer, and eventually to be able to make a difference for these men. Men did not know a lot about prostate cancer, and the reason for that is most probably because they did not ever have the opportunity to listen to awareness campaigns. And then the traditional healers was a group of men and women that seemed to be quite well informed about prostate cancer, but all these groups, different groups, really need prostate cancer awareness and capacity building in their midst. Next. We need national and provincial governments to get involved, and we need basic policies and guidelines for the screening of prostate cancer. we also need to get more urologists involved to develop a dedicated plan for prostate cancer management. Next one, please. We need further research. We need the communities, and we need advocacy on prostate cancer and community engagement to strengthen awareness and education programs. Next. I really hope that today will make a difference for you, that the information that you obtained here will be useful for you to go out and do something about prostate cancer. Thank you very much.
Thank you, Prof. Riana. That was really informative. And thank you for the valuable research that you've been doing. At CANSA, we are committed to educating the public. And it's so important, like you mentioned rightly, Dr. Desmond Tutu said that we need to find the source. We can't just keep looking at the results and try to fix it from the wrong end. So thank you very much for that. I do see we have some questions in the chat, and I just wanted to inform everyone here that we will find ways, or we will answer all questions via our cancer help desk in the coming days. Prof. Riana will be given all these questions, and she'll give you her feedback by email. Thank you very much for those questions, so please keep them coming. And I also want to introduce to you Mortimer Julius. He is a prostate cancer survivor, and he is also part of the Cancer Psychosocial Support Services, which is men supporting men. And we are so grateful to have Julius here, Mortimer here, who will be telling us more about his experience and his road with cancer and his journey. And we'll also give Prof. Riana an opportunity to ask Mortimer some questions about his treatment and his experience. Thank you, Mortimer. Thank you for being here.
Hi, good evening, everybody. Yeah, now you can see my face. I'm a 62-year-old male. And Joanie, I'm just gonna go off from this question that was sent to me. How did I find out that I had prostate cancer? I took ill. Oh wait, I used to go to the doctor, and every time the doctor would tell me I've just got a bladder infection, until one day I couldn't move. And I went to a different doctor. And this was over a weekend. And when I got to the doctor, she gave me one look, told me to go and urinate, which I did. And she did a test, and she immediately wrote me a referral letter to go see a urologist. And that sort of put me off, because she took blood as well. She drew blood on me that Saturday. Gave me a script to help with the pain that I was having. Until that was in March 2022, until I went to the urologist and they did a test. Then, about 2-3 weeks later, I got a phone call that I have to come and see him urgently. And then I found out in March, this is it, you got prostate cancer, you stage 1. Gave me the options. And then I had to tell him, wait a minute. This is not how the thing works here. You tell me I have this, let me get involved with my family, and then I'll bring my wife in, and then we sit, and then you tell me about options, because I need her in my presence, and I need to share this news that you gave me. You can't just put me in a fist blip here. Anyway, that's how I found out, by going to him. But in that period, I was also very, very the Helen with the doctors, because for years I've been going to the same doctor. It was family doctor, and treat me just for infection. So that wasn't on. Be it as it may, June I went for my MRIs, I went for CT scans, blood tests, and September I had my operation, my robotics, so they did that. So it's a year ago now, so I'm busy with post-op treatments at the moment. But it wasn't an easy road. It was something that mentally, I always thought that I was a strong man, mentally and physically, and it put me into a spin. You know, where do I go from here? What about my family? I'm not working, I'm retired. I retired in 2017. I don't have major debt or children at school or things like that. So that was one comfort. But yeah, I'm 62. I've got 3 grandchildren. I've got all the things to live for. How long am I gonna live? How far is this thing gonna take me? But then again, the support from my family and friends, family, my church that I belong to, the membership that I spoke to, that helped. And then something told me, come onto the website of CANSA SA. That's how I joined the group. So I've been in contact. Well, last week we had a Zoom meeting with Emmanuel, and one of the members shared. And on the men's group that we have on our WhatsApp site, we chat regular, and I find that is a source of comfort and also a source of strength for me. And this afternoon, I just received a phone call from the doctor, and on the 30th, I'll be starting my external radiation treatment, because when I went for my nuclear meds, that thingy that they put you in that scanner and they inject you with that nuclear substance, but they found that there is nodules. So they would like to remove that by radiation, so that, I guess after this, to use the term, being cleared of whatever residue that is still there. But I'm not good with that. That anger, that sort of depressed state, that one that you just want to give up, that feeling has left me. I don't feel like that anymore. At present, I'm on hormonal treatment. I received a hormone injection 2 weeks ago. So my next one that I will go is on the 24th of January, 2024. That's for my next hormone injection. I don't know anything else you would like to know, Professor.
Sorry, just unmute there quickly, please. Thanks.
Thank you. Thank you very much, Mortimer. I am sorry for you having to go through such an ordeal of not being diagnosed and then diagnosed, and it's a bad diagnosis, was a bad diagnosis for you. But in a way, you really, what I heard was that you grew as a person in the midst of the disease. And I think what you are explaining to us is so precious, because we as physicians also need to understand it's not a number that's sitting in front of us. It's a patient. It's a human being. And sometimes I know we can come across as a state of the matter, and that's only what's important. I think your history explains something very important, in the sense of all of us who know about the risk age for prostate cancer, and it means that we, as friends, family, as patients ourselves or whatever, we should have a high index of suspicion. If you are in the age group that can develop prostate cancer more easily, make sure that your doctor ticks the box for your PSA annual testing, or every 2 years, depending on your age. But after the age of 40 in South Africa, if you're of Black ancestry and if you have a family history, please get tested. Also for maternal links with breast cancer, get tested, please. It's a very emotional roller coaster that you went through, Mortimer, and thank you for sharing it, because we all can identify how we would have felt amongst, during the time of your suffering. I think what you are doing now is great, and that is to share with other men your experiences, how you came to terms with it, but also how you're managing it yourself. So maybe it's an obvious question, but I want to ask, what can we as physicians do differently next time when somebody in your circumstances come and sit in front of us with not localized symptoms, generalized symptoms? What should we do and what should we not do?
Professor, let me just divert from that. We as men should really get away from the stigma. Yesterday I spoke to Lucy, and this was my words to her. I entrust my wife to go to a gynecologist, a man I don't know, but I trust what he does to my wife with his examinations. Yet I am too scared to go and have myself checked out, because putting his finger up where it's not supposed to be is taboo. So that is the first thing that we as men across the whole of South Africa must get out of their mind. If I entrust my wife to see to that aspect of our life, because it's our lives, we in unity, then I should do exactly the same, because in that manner, I respect my wife and she respects me. That is in a family dynamic, but it also from a medical standpoint of view. Now comes to the medical person, the trained physician. When I come in there and I say, Doc, I couldn't urinate, I'm struggling. Don't give me a pill and tell me to drink with this pill so much liters of water so that when I get home, I stand like an elephant, urinating. If that is the case, then do, and tell me to do, I want to do a prostate test on you. Where can I run to? I'm in your surgery. And explain the reason why you do it. That is what the medical profession is lacking. Explain to me as the client or the patient, look, this can stem from this, and maybe this is the symptom, this is why. Come, let's do that. And if you don't want to do it now, go to your house, go to your family, explain to them why, and this is the test that will follow. I think that gives me time to digest what is going on, time to create a support channel where my family will support me in that. And together then we can walk the road, because should it be positive, that burden would be so much less because I have the support of my family instead of afterwards. Now you discover, hey, I'm being diagnosed with it. And now I must bring that news. It's like now throwing oil onto a hot fire. They are not involved in the first process. But if they had to be involved in the first process with the testing from the first time to when the results came out and then the way forward, then everybody would be, then that stress won't be there. We can go to the medical aid, and if we don't, we can get in contact with Cancer Association or some institutions that will help with us if we have to go to public hospital in such cases. Just to alleviate that stress, that burden of, how will I be able to afford this? What's it going to do to my family life? What's it going to do? How long am I going to live? So it's a two-way street that comes in. We cannot just solely blame the medical profession. We have to blame ourselves also in this instance because of that taboo factor that, well, why are you going to stick your finger up my ass? That is not, I'm sorry, I'm being blatant about it, but that's just how it is, Professor.
Thank you very much, Mortimer. I think we will have to think better about ways to start with boys in puberty to tell them eventually about prostate cancer. In the same way, we tell them about testicular tumors and that they have to examine their scrotum for possible testis cancer, but also about one day you may develop symptoms of prostate cancer, or your uncle, or your father, or your neighbor, or whoever. But the point is, just sensitize these young men when they can still be taught to consider certain factors. And it will make a difference for the rest of their lives. I think you and you mentioned your church. I think that's also a very good place to do the sensitization about prostate cancer. Thank you very much, Mortimer. Thank you, Joanie.
Thank you, Mortimer. Thank you, Prof. Bornman. Mortimer, thank you for that honest account of your journey with cancer and for being so open about your emotions and the effect this has had on you and your family as well. And just building on that, I'd like to know if you have a message for those men with prostate cancer or other men living with cancer at the moment.
The only thing I can say is don't give up hope. It's not, it's a battle that we're fighting. I wouldn't say that we have guarantees or we don't have guarantees. For me personally, I'm over the anger. I'm at peace, but it gave me it's giving me a purpose. I can live. I can live my life today that has been granted to me. I can live in peace. I can live in harmony. I can live in love. And I can live in comfort. Comfort of my family. Love from my family. Peace with my neighbor. Peace within myself so that I can carry on my battle as far as this ailment or this disease. It's not a disease. Is concerned. And yes, even though I go to the doctor, And yes, I go to my treatment, and I know that we go for various treatments as far as our cancer is concerned. And when we come home from there, we don't always in the same space of mind. But when I come home to my family, and that already grants me comfort. So, yes, when we feel down, go on to the group, your WhatsApp groups in your respective areas, and tell them. If you vent, but it's you vent to somebody that understands what you are going through. I cannot go and vent to somebody who is healthy. He's not going to understand what I'm going through. He's gonna say, "Ah, shame," you know. Well, what advice can he give me? He hasn't walked the road that I'm walking. But if I vent to somebody who's walking the same road, that person will understand. And that person will be able to comfort me, would be able to give me better direction into which journey. Because they walk that journey, they've had the experience, so their experience will then become mine. And in that way, you will have harmony and you will have peace. Our struggle is still the same, but what we need to have is peace within ourselves. And then we can walk this road together. And I think in that way, when we have peace and acceptance about our ailment, I think the road to recovery is so much stronger then. That's my outlook, and that is what I would like to share to my fellow members who walks this road with us. That's about it.
Thank you, Mortimer. Thank you. That was really profound. And I just applaud you for coming to a realization of that having a soundboard from people who are in the same journey with you really helps you to come to peace. And thank you. Thank you for being so honest, and thank you for sharing. We really appreciate it. Thank you. I see we still have another 10 minutes to go, so I'm just going to really quickly look at the chats and see. We have some questions for Bornman. If you wouldn't mind just giving us a few quick answers. But like I mentioned earlier, if there are any other questions, our guests are really very welcome to reach out to the Cancer Help Desk. The information is on our website. And we will get back to you with the answers. And also, if you want to send Mortimer a message, thank you. We'll relay that to him. Thank you very much. I see Akil has asked, hi, Prof B. Thanks for the informative talk. I would like to know, in your opinion, what are the best treatment or therapeutic options for early onset for the colored population, if there is any data? And what is the reoccurrence in this population group? I agree that we need to study this disease ourselves in our population in order to get ahead of it. I appreciate your time for sharing your knowledge. Thank you, Prof. Bornman.
Thank you very much for the question. I am only dealing with research to find out why are men developing prostate cancer. I'm not involved with the management of diagnosed men with cancer. So I'm so sorry, but I cannot help you. My guess would be if you contact one of the medical schools, the departments of urology, they should be able to assist you in addressing this, please.
Thank you, Prof. And then we have another question from Sherry. He says, hi, Prof. Does being sexually active reduce chances of developing prostate cancer?
No. Being sexually active will not prevent or worsen your chances of developing prostate cancer. During ejaculation, the prostate also the fluid is compressed through the prostate, and the ducts empty in the posterior urethra. So it helps to emptying the prostate, but there was a story long time ago, allegations that it could make a difference in prostate cancer, but there's no scientific proof for that. Thank you.
Thank you, Prof. I just see there's a really quick question from Bobby as well. He asked if this information will be available online. Bobby, we will distribute it. It will be available on YouTube. And if you send a message to our info line, then we will, to the help desk, excuse me, we will definitely send through that information. I want to thank again our guests for joining us today, Prof. Bornman, Julius, Mortimer, excuse me, keep making that mistake. Thank you for joining us this evening. Thank you for the unbelievably important information and experience that you've shared. Prof. Bornman, I just want to highlight again what you've been saying is that we need to be aware that men need to go for PSA screenings from the age of 40. 40 years old doesn't, everyone thinks this is an old man's disease. 40 isn't that old, but please go for the PSA screenings. Lucy is putting the information in the links in the chat. CANSA does offer full blood antigen tests at our cancer care center. So please go to our website and contact your nearest cancer care center, and we will give you more information on that. Prof. Bornman, the research that you're doing is, I can just say again, invaluable. I know that our head of advocacy, Zotwa, has been working really hard at getting traditional healers involved as well, and pushing government to help us get ahead of the curve to stop this disease from happening, because people don't need to die. And Mortimer, again, thank you for being so honest, sharing this information in such an honest and open way, and making yourself vulnerable. It's been really touching to me, and I'm sure to everyone attending tonight. Thank you for sharing your experience with us, and for the insights you've given. I'm really sure that there are lots of people here who have experienced a shift in the way that they're thinking about their cancer journey as well, thanks to the way that you've presented your own journey. So thank you very much for that. I just want to say that CANSA does offer free psychosocial support services. We do have the Men Supporting Men group, and Lucy also put the information in the chat box for that as well. And please reach out to the nearest cancer care center, reach out to the cancer help desk, and find a group of people who, like Mortimer mentioned, they are going through this journey, they are sharing their experiences, and they are a soundboard, and they understand, so that you can go back to your family and you can be with your family. So thank you, Mortimer, again. And I think what we just need to take away from this webinar is women, like Prof. Bornman rightly explained, sometimes men needs to be taken by the ear, need to be taken to the doctor. Mortimer also said it is a procedure that is feared by many men, but it's very important. Again, it's something that can be prevented. So I want to thank you both again for sharing your knowledge, sharing your experiences, sharing your research. And I want to also encourage everyone watching to reach out to the Cancer Help Desk if you need any information, if you want any support, and we will put you in contact with the right people. Thank you, everyone, and have a lovely evening.
Hi, что ли? Sign here?
Mr. Sitole? Ready for your blood test?
for being so honest.
Mm.
Thank you.
Very important. And we hope it will inspire other men.
Yes,
I'm a,
absolutely.
I must thank CANSA SA for having this, because looking back, if I would have still been in a dark place if there weren't any of these methods available to help you in your on this road of recovery. So yeah, thank you, ladies.
Oh no, thank you. It's a pleasure.
Ever.
We appreciate these sessions. I think if we can at least educate and encourage one man to, you know, to learn about his body, or to teach his son, or to teach his brother or family member, or, you know, that